Great. So thank you very much for all of you coming back to this last and final session of this spinal surgery webinar course. That's been a great day so far, and I'm looking forward to the next 4 speakers with very interesting topics which affect our practice day in, day out. I'm going to hand over the chairmanship of this session to. Thank you very much for all of you coming back to this last and final session of this spinal surgery webinar course.
There appears to be an echo again, Naren. Is it
That's okay. I've sorted it out. Sorry about that. And so the session will be chaired by Professor Florian Ringer. He's the professor of neurosurgery and chairman of MINDS, one of the important units in neurosurgery. Thank you very much, Florian. It's an honor to have you. And Dr. Komar Prasad from Narayana Health in Bangalore, who has been the co-organizer of this meeting, as well as when we have our INRC in Bangalore, when all the current problems are settled. So thank you very much, both chairmen. I will hand over to baton to you. Thanks, Komar.
Thank you, Naren. So we are starting the next and the last session of INRC Spinal webinar series. Welcome back to the session. Today the first speaker now is Dr. Sushil Patkar, Senior Neurosurgeon, Spinal Surgeon from Pune Hospital and Research Institute, Pune in India. So welcome, Professor Sushil Patkar. So glad to have you here today. So the floor is yours, and he'll be talking on lumbar radiculopathy.
So I can share the screen now.
Please, thanks.
Are you able to see this?
Not your presentation yet. Click on the share button from there.
Okay. Can you see that now?
It's coming. Yeah. Thank you.
Yes, it's coming now.
We can see it, sir.
We can see it now. Please.
Very good. So in this COVID pandemic, there has been a pandemic of webinars also. And I've been giving these talks all over since last 2 weeks. There are so many talks all of us have been giving all around. So many times, the slides might be things which many of them have seen, but maybe some changes. So I thank Naren and Komal for this opportunity to speak over here. And I appreciate that you guys are on Sunday sitting there listening to me. Thank you very much. So I will be talking about lumbar radiculopathy, which is a very common clinical condition which is seen by most of us in our private practice. And I have no disclosures apart from my teacher and mentor, Professor Ramani, who is now 84 years old. And I learned ropes of spinal surgery from him. And these are the 2 people from whom I spent some time and learned endoscopic spinal surgery. All of you, of course, must be knowing Sebastian Rutten at Harne in Germany and Gun Chai at the Buridul Hospital. And probably these 2 should be credited in training so many neurosurgeons all over the world and orthopedic surgeons, and kind of, bringing about a tilt in lumbar disc surgery towards endoscopy. Today in my talk, I'm going to evaluate in which direction we are going and whether that direction is correct, or still a lot of water has to flow under the bridge. So what is lumbar radiculopathy? Lumbar radiculopathy is pain in the lower back and hip, which radiates down from the back of the thigh to the leg. Most common cause of lumbar radiculopathy is prolapsed lumbar disc. There are many causes for this condition, but in a given clinical situation, in the right age group, the most common diagnosis is a prolapsed lumbar disc. Lumbar radiculopathy refers to the disease caused by compression of the spinal nerve. Why does the nerve get compressed? Because the disc, because there's inflammation, and because the nerve gets swollen, that swollen nerve gets trapped and gets pinched, and the pain radiates along a particular pattern which the nerve follows. And out of a given 100 patients, 95 are going to have radiculopathy involving the last 3 roots. So you can notice now in the foramen, there is propensity for the nerve to get pinched because of anatomical structures, because of the disc, the joint capsule, and in a given nerve, there are the roots, there is a dorsal root ganglion, and as you go further, it's a mixed nerve. Now, these are 3 different structures, and they behave differently in response to pain. There are 2 types of injuries. There's a mechanical injury because of elevated intraneural pressure, which gives rise to ischemia. Ischemia gives rise to neuronal damage and to pain. And there's a chemical injury, which sets in inflammation and again gives rise to pain. So both the components of the disc will give rise to, there's a chemical injury as well, there is a compression. The spinal nerve roots are mainly supplied, they do not have any perineurium. The spinal nerve roots are supplied by cerebrospinal fluid is what supplies nutrition to them. And the peripheral nerve supply blood vessels are supplied by blood. The dorsal root ganglion is the most sensitive structure to mechanical compression and is the first structure which elicits pain whenever there is compression in a nerve root over the nerve root. What we have to realize when we see this patient is that the size of the disc herniation has not been found to have any relation to the severity of the patient's symptoms. And I think this is the most important clinico-radiological mismatch, which has created such a lot of confusion with many neurosurgeons ending up operating patients who really did not have a very significant disc prolapse, but guided by the pain they offered them surgery. And these patients over a period of time would have become all right. And this is what earned a bad reputation for lumbar disc surgery. Now, most of the time, you have to understand the disc compresses on the root, which is the traversing root, which is going to come out below the next pedicle. So at L4-5 disc, the root which is going to get compressed is the L5 root. Only when the disc is very large or upward migrated, then the exiting nerve root will get compressed. So we have to know this anatomy. It is very important for a junior surgeon to know which root is compressed by the disc at what position. So a far lateral disc will compress on the root which is exiting, and a standard posterolateral disc will compress on the root which is traversing. But sometimes you can get a double root entrapment if it is very large and migrated upwards. Radiculopathy follows radicular pain. The term radicular pain and radiculopathy are not synonymous. With radicular pain, we are talking only about pain, but when we talk about radiculopathy, we are talking about sensory deficits, motor deficits, and various syndromes. So radicular pain and radiculopathy are not synonymous. Radiculopathy is obviously the next step of radicular pain. So what is the demographics? It is a very common condition. Very rarely one will not come across a patient who has not had at some point in his time some element of radicular pain. We are all programmed to get this degeneration, get some amount of radiculopathy, and fortunately most of us become all right. It is in those patients, 10 to 15% of the patients only, that the symptoms will persist for more than 6 weeks, and those are the ones which will seek and need your help. The lumbar radiculopathy is the most common form of neuropathic pain. However, the diagnosis of lumbar radiculopathy is still largely not properly known. What causes the pain, whether it is the inflammation, whether it is the compression, and still argument goes on. The exact mechanism, what elicits pain, is not yet properly understood. This is the program. We all are programmed. There's some element of this degeneration, then some element of instability, and finally we all auto-stabilize. It is when it becomes in excess, that is the time the patient seeks you. If there's too much of, nobody can escape this cascade of this degeneration, instability, and finally stabilization. When it becomes in excess, it results in a disc hernia, or it results in instability with spondylolisthesis, or it results in canal stenosis. We are all programmed to become old, degenerated, kyphotic, and fused. Lumbar radiculopathy remains an important, largely unresolved medical problem. There is clear interest in identifying the cell populations affected by disc herniation inducing radiculopathy and the role of neurotransmitters and the receptors that mediate the symptomatic and functional deficits of radiculopathy. Presently, our ability to translate pain complaints and sensory abnormalities into specific pathophysiological mechanisms that have treatment implications is in its infancy, because there is such a large clinico-radiological mismatch. You get patients with severe pain and the MRI is nearly normal, and you get a patient with a large sequestrated disc with minimal symptoms. On one side, you have patients with gross neurological deficit, and on the other hand, you have large sequestrated discs which resolve on their own without any treatment. So the onset of symptoms in patients with lumbosacral radiculopathy is usually sudden and usually, sitting, coughing, sneezing will exacerbate the pain, which travels from the buttocks down posterior to the posterolateral aspect of the leg, ankle, or foot. And most of the time, clinical history and clinical story of the patient is sufficient to tell you that the patient has got radiculopathy. Additional investigations are not required unless and until there are red flags. And what are the red flags? If the patient is having fever, weight loss, if age is less than 20 or more than 50, there is progressive neurological deficit, or the pain persists for more than 4 to 6 weeks of duration. Most patients are going to become all right. Those who are not becoming all right, or those who are falling into these categories, are the ones which need to be investigated by doing an MRI or X-rays and MRI, etc. But otherwise, by and large, most are to be treated with analgesics, anti-inflammatories, and a good back exercise program. So what is the differential diagnosis? The commonest differential diagnosis is prolapsed disc, instability, infection, tumor, trauma, and disc prolapse in pre-existing lumbar canal stenosis, especially if the patient is an elderly patient more than 50 years of age. So whereas the nerve can get trapped, there can be instability, there can be infection, there can be a neurofibroma, there can be a metastatic, all these can produce a radiculopathy, and these are the causes of what are known as the red flags. Otherwise, in a standard patient, a young adult, male or female, with sudden onset of radicular pain, the cause invariably is a prolapsed intervertebral disc. Clinically, of course, there are various tests, not much is required, but a standard straight leg raising test is sufficient to diagnose the pain between 30 to aggravation of the pain between 30 to 70 degrees, tells you that the patient has got lumbar radiculopathy of the lower root. And then, of course, there are various clinical tests to diagnose which root is involved. We all know that. Electrophysiology is not required in most of the cases. I do not find any reason to subject the patient to EMG nerve conduction analysis unless and until the patient has come very late with some amount of wasting, mainly for prognostication, or the patient has got associated diabetes. Otherwise, in a standard case, EMG nerve conduction has no role. The standard treatment, of course, is analgesics. Some people use steroids. I also use steroids for the first 2 or 3 days if the patient has come with severe pain. And then most of the patients, they will be asked to remain within the limits of their pain. And once the pain subsides, then a good exercise program of McKenzie-based treatment is very helpful in relieving the pain of patients with prolapsed lumbar disc. But of course, it should not be started in the phase of acute pain. Epidural injections, there is very limited research. Yes, transforaminal injections are the best. I have done quite a few of them, and I still continue to do them. But I found that many patients with oral steroids, oral analgesics, and if explained the natural history of the disc prolapse, invariably do well and do not require these injections. Plain radiographs are often unremarkable in patients who have radiculopathy that is secondary to herniated nucleus pulposus and are not necessary if there are no red flags. Persistent or progressive symptoms beyond 4 to 6 weeks requires a full workup, which consists of MRI, dynamic X-rays. Only if surgery is to be contemplated, then a CT if you are going to contemplate fixation, a contrast MRI if you want to rule out presence of infection is necessary, Bone scans in certain unusual situations like previous history of malignancy or there is a doubtful enhancement, then definitely bone scan is also a part of investigation for lumbar radiculopathy. So what does the MRI show you? The MRI is a very beautiful investigation. It will show you the MRI, it will show you the disc prolapse. It is also used, if you study the axial MRI, you can study the far lateral disc properly. And in this case, you can see that there is a pre-existing canal stenosis with the disc prolapse. CT scan, if you are contemplating surgery, CT scan, I think, is a very invaluable test which must be done, especially this to study the bone stock. If there is a large disc and you are contemplating a T-leaf procedure, then you are going to require to study the bones if you are going to do a pedicle screw fixation. In the MRI, I always insist that the MRI should be done in the oblique manner along the root, which is being studied, to study how the root is undercompressed and where is the element of compression. So sitting at the console and getting the MRI that you want is very important. It is, you cannot just leave it to the MRI technician when you're looking for a disc, and sometimes the disc is there in the lateral recess, it is there in the foramen, and also there is a far lateral disc, and you may miss that if you rely just on the technician. Another very important structure which needs to be studied on MRI is the paraspinal muscles. And there is a lot of research coming in that disc prolapse is an effect rather than the cause, but the effect of poor musculature and of wasted muscles in the back, which gives rise to spinal imbalance, which gives rise to increased stress on the disc, which gives rise to annular tear, and which gives rise to disc prolapse. So just focusing on the disc is not important. Studying the muscles, for example, see this in this patient, you can find the muscles on one side are definitely smaller and impregnated with fat, and they show there's muscular imbalance of the spine, which gives rise to increased stress on the disc. Now there is a lot of talk, what to do now if the MRI is not matching. So if you see the literature, as of now, the discrepancy between clinical neurophysiological and neuroimaging exam in lumbar spine result that it is left to the neurosurgeon to decide whether the given patient should be offered surgery or not. You cannot have any clear-cut criteria even in 2020 that yes, this patient should be operated and this patient should not be operated. It can safely be concluded that the treating physician should put more emphasis on the history, the clinical examination, make the inference by these, and then should correlate the clinical findings with the MRI to reach the final diagnosis. Unfortunately, patients come with MRIs and many doctors make the decision to operate by looking at the MRI rather than by examining the patient. A clinical correlation of the magnetic resonance imaging with symptom complex in the prolapsed lumbar disc. This study was published in 2013 from Indian Journal of Orthopedics, and I think it's a very, very good study. So what are the indications for surgery? Intractable pain, numbness, symptoms affecting activities of daily living, demands on that patient's life, and medical fitness over issues over time. I always feel that a good consultation should consist of diagnosis, whether there is a concordance between what is seen on the MRI and the patient's symptoms. What are the alternatives available to the patient? What are the benefits of the alternative which you are offering? What are the risks of each? What are the costs? What is the natural history if left untreated? And if required, second opinions. I call it DA, BRC, NH, and SO. Every patient must, it is his right that he should get a DA, BRC, NH, SO. Only then he should make an informed choice rather than an informed consent about whether he should undergo surgery or not undergo surgery for any condition, not just prolapsed lumbar. So whenever we talk about surgery for lumbar disc, we have to go back and see the stand on the shoulders of our forefathers such that our horizons are widened further. We all know these are the people who started lumbar disc surgery. This is Mixter and this Love who described the interlaminar approach. Then Yasargil and Casper who started microlumbar discectomy. And of course, my mentor was popular for microlumbar discectomy in our country in 1990s. When I had just finished my neurosurgical training and joined him, that is the time he was pushing this operation of PLIF for lumbar disc prolapse, and that was the trend those days. Microlumbar on one side and the other side, very extensive procedure of PLIF, which used to go on for 6 hours. But then, of course, things were yet crystallizing that time. But there is no doubt that he contributed to the understanding of lumbar spinal surgery. And then as this all was going on, people were not sure, whether really patients with lumbar disc required surgery. And then the SPORT trial came out in 2006. Patients with persistent sciatica of lumbar disc can improve both with surgery as well as with conservative. So SPORT trial changed the whole outlook of doing lumbar spinal surgery, of lumbar disc surgery. Backache, backache, backache. If you study the papers coming out after lumbar disc surgery came in, it was very easy to relieve patients of radicular pain, but backache continued to plague surgery of lumbar spine. Now, why did this backache plague lumbar spine surgery? So people went back and they thought that this was because of the trauma caused to the paraspinal muscles, to the trauma caused to the bones, the trauma caused to the ligaments, which had no role in production of the pain. The paraspinal muscles, the ligament, the ligamentum flavum, or the bone of the lamina, the facets, they do not produce pain. The pain is produced by the disc, and the disc is, pressing on the root. So then this operation was like taking an axe to cut off a flower from a plant. And therefore, many new things came in, like, for example, from the mastoid, people went on to the Gilpey, from the Gilpey onto the Williams, onto the Casper's retractor, and to smaller and smaller incisions. But one thing remained, that it is very important while doing this surgery to trace the root outside and go outside the foramen with a probe, because many times what disc comes out, there can be a small fragment lying along the root and into the foramen. So therefore, the trend was towards minimalization. And then came Smith and Foley on to the scene, and they devised the tubular retractor, which was nothing like microlumbar surgery, but instead of stripping the muscle, they dilated the muscle with the tubular retractor. But I tell you that all these retractor systems, whether they use the Testandu or whether they use the Foley's this tubular retractor from Medtronic, they all involve damaging some element of the multifidus muscle, removing the lamina, removing the ligamentum, which again have no role whatsoever in production of the pain which is seen with lumbar disc prolapse. Also, whenever these retractors are put, if you will note very carefully that the first step of the operation is to remove some amount of muscle which is just in front of the opening of the retractor. So it is not a muscle saving procedure. The procedure, the first part of the operation is to pull out some muscle with a biopsy forceps rongeur, whether you use the Destandu or whether you use the Foley's. So I call it, minimal access surgery rather than minimal invasive surgery. What you do inside is the same like you would do in a microlumbar disc. And of course, we have got the Indian version also. This is what I use. This is made by Pictor, and we use this radiolucent tubular retractors. There are many ways to skin a cat, But one thing is that the Asian research gave rise to stimulus to microlumbar for endoscopic discectomy. They started studying the amount of muscle damage and the amount of elevation of muscle enzymes following minimalization, and that is what gave birth to minimalization. The progress of surgery lies in making the operation smaller and smaller, and the final progress lies in finding a way to treat a given surgical problem without operation. That is the real progress of a surgeon, of a surgical technique. So from here we went on to this, and then they went on to doing microlumbar, and now the biportal endoscopic disc surgery. Of course, Hijikata and Cambin was the first person to describe the triangle where you could safely enter the disc without disturbing the paraspinal muscle, without disturbing the lamina, without disturbing the ligamentum flavum. And then, of course, Anthony Young, who described the inside-out technique, where they entered the disc first and pulled out this disc tissue. But of course, it was not very successful because those days, the operating channel was very small. The maximum biopsy forceps was 2.5 mm when Young began. Young and John Chu started this procedure on the west coast of America. And many times they were criticized for not doing unnecessary and unindicated surgery. It was Rutan who came out with the concept of entering the foramen directly and going directly for the prolapse segment. I myself went and spent some time with him to see what he does, and I was quite impressed that the entry was directly into the foramen, and directly the prolapse component was addressed, which was unlike Anthony Young's technique. Is the trade worth it? Is the decompression adequate? Dural injuries, recurrences, the amount of radiation during endoscopic procedures. Does it really result in decreased post-operative pain, decreased hospital stay, and better outcomes? We will evaluate this. I don't know. I'm not very sure whether the trade is worth it, in spite of having delved into both of them. If we see 2011, the trial was funded by the Dutch Healthcare Insurance Board. Does minimally invasive lumbar disc surgery result in less muscle injury? Post-operative evaluation of CPK and the multifidus muscle showed similar results in both groups, although patients who underwent tubular discectomy reported more lower back pain during the first year of surgery. This is the first bombshell, People were saying that tubular retractors were superior. Tubular retractors were not superior. Then a comparison of percutaneous endoscopic lumbar discectomy with open lumbar microdiscectomy, Korean meta-analysis. What is the conclusion? While percutaneous endoscopic lumbar discectomy showed better results than open lumbar microdiscectomy in some items, open lumbar microdiscectomy still allowed good clinical results and is therefore reckoned that a randomized control trial is necessary. This is 2018. Still, they are not sure. Still, nobody is sure. Endoscopic lumbar spine surgery, the state of the art, 2019 Neurospine. This is published from Korea. It's a combination of 3 journals: Korean journal, Japanese journal of spinal surgery, and Taiwan journal of spinal surgery. The place in the world where, if you take, 100 endoscopic procedures, 80 are done in Southeast Asia and 20 are done outside Southeast Asia. And what is the conclusion? Additional high quality research assessing the outcomes of endoscopic lumbar surgery is certainly needed and currently expected to give the rapid expansion in the field over recent years. Asian Journal of Spine, 2018, clinical correlation between muscle damage, obesity, disability index score, and after open lumbar disc surgery. Does open surgery reduce functional disability? Open lumbar fusions. Now, these people have studied fusion surgery and they feel that there is a bigger injury for the multifidus muscle, but that does not hold true for standard lumbar microlumbar discectomy. European Spine Journal again. Long-term results of various operations for lumbar disc herniation. This study was published by none other than George Dorman, who has been our friend and colleague in the World Federation. I was there with the World WFNS Spine Committee till 2019. And see this study, 39,048 patients. 39,048 patients. What is the conclusions? Patient who had microdiscectomy, endoscopic microdiscectomy, or the classical operation, laminectomy, laminotomy, all had approximately 79% good or excellent results, and none of the operative procedures gave different outcomes. None of the procedures. Large analysis. What happens that many times when you have a hammer in your hand, you search the nails and you feel that the hammer is the best instrument. One shoe cannot fit all sizes. Incidence of low back pain after lumbar discectomy for herniated lumbar disc and effects on patient-related reported outcomes. See, this is what triggered the entire research towards minimalization. Why people went on to minimalization in lumbar spinal surgery was because of the low backache. And the incidence still remains 15 to 25%. I myself published a little bit of my work. I have published the technique of percutaneous. I was the first person to publish in Neurology India the technique of endoscopic disc surgery. The big problem which tilted me back away from endoscopic disc surgery was radiation. See, as neurosurgeons, this is a small aspect of our work. In addition to disc surgery, we are doing pedicle screws, we are doing radio frequencies. We use the CM very frequently during our procedures. And I tell you, I am sure that most of the surgeons, they find using a thyroid shield, using an eye shield quite cumbersome. Our hands are exposed to the radiation, and you'll see that the average for an experienced surgeon who's dedicated to spinal surgery is 2.5 minutes. I had visited the Wilsey Hospital last year in Korea, and I found the gentleman doing a 2-level 4 screws percutaneously, and he used the CM 118 times during surgery, 118 times. So I don't think it is so innocuous and to be taken lightly. the amount of radiation exposure to the surgeon during endoscopic procedures is very high. Now there is a solution. The uniportal system which Max Moore has come out with, which involves the only during docking to do the CM, and then this uniportal system has a large operating channel through which drills can be passed, through which big biopsy forceps can be passed. But the biggest disadvantage is that it has only one port, and one of the complications is post-operative seizures, because there's continuous high pressure water irrigation, and this continuous high pressure water irrigation, which endoscopists don't talk about. They don't talk about this problem. They cannot operate. You can only pass one instrument at a time. Either you pass the bipolar or you pass the biopsy forceps. You cannot have a bimanual control. And therefore, how do you do the hemostasis? Is by increasing the water pressure. And when you increase the water pressure, there's always a chance of water intoxication. This, according to me, is probably the future of lumbar spinal surgery. That is a biportal surgery technique where you have an endoscope through one channel and the instruments through another channel and a free flow of water. So best of the both worlds. So you are able to go down and have best of the both worlds. So this is how you dock your instruments to the lamina. We have started doing this, but of course it's still in infancy. And it is possible to achieve comparable results, if not better. The most important thing is that you do not require any special instruments. It can be done with the standard arthroscopy or standard percutaneous endoscope. Even the drills, the standard drills which are used in neurosurgery can be passed to the operating channel. Otherwise, for most endoscopic procedures, you require a dedicated drill system, and it keeps on increasing the cost of the procedure. So this is possible with biportal endoscopic discectomy, and even transforaminal compressions or decompressions are possible. So lumbar disc history, herniation, natural history, role of physical examination, timing of surgery, treatment options, and conflicts of interest. What are the conclusions? There is no treatment modality better than rest. What is the conclusion? There is no treatment modality better than rest. No patient should be offered surgery before 6 weeks. I really doubt that this is being followed everywhere in the world. I really doubt it. Otherwise, people cannot have such large numbers of disc surgeries. The sport trial continues in 2016, and still there are no differences between surgery versus conservative treatment. So sport 2002 and sport 2016, same results. But yes, we cannot continue like the ostrich. A PubMed search shows that more than 80% of the publications of endoscopic surgery are from Asian countries. Why? Is it that the Europeans and Americans and the British are not deft enough to learn endoscopic disc surgery, or they don't like this endoscopic disc surgery? In spite of the learning curve for endoscopic surgery, once the surgeon is familiar with it, he can achieve comparable results and sometimes better clinical results as conventional microsurgical operations. Says who? Says Michael Mayer. The greatest challenge in this learning curve is resting on us senior surgeons to promote the younger generations to take up endoscopic disc surgery and find out whether this is the truth. Whether really endoscopic disc surgery benefits patients, does it improve the results, does it decrease the cost of the operation? Old monkeys cannot learn new tricks. Unnecessary spinal surgery, prospective analysis, 1-year study. Nancy Epstein, what does she say? That spinal surgery increased all around the world. More nerve injuries which occur with minimal invasive lumbar surgery. Let someone tell the truth. Is somebody hiding the truth? I don't know. Way back, there was an article published, rape of the spine. I don't know whether this rape of the spine is occurring again with the endoscope. I'm not sure. It is bearing on us to offer best versus reasonable treatment, whether the treatment that you offer is best or reasonable. I think a reasonable treatment for the correctly indicated patient from Icarus, between Icarus and equinomatus is what is necessary. Truth will sooner come out of error than from confusion. We should not be dogmatic. Thank you very much, my dear friends.
Thank you, sir. Very interesting, very thought-provoking. And you have analyzed the evolution of endoscopic approaches for lumbar radiculopathy. I have a question for you. This advising 6 weeks of rest in the presence of weakness. Suppose this
Not
patient
rest. I did not say rest. I said don't be in a hurry to operate till 6 weeks.
Yes, yes. So if there is a mild external EHL weakness, dorsiflexion weakness, and patient in severe pain, and there is an extruded disc, still would you consider a period of rest?
Of waiting, not of rest. And I feel that an extruded disc has got better results in non-operating than a non-extruded disc. Extruded discs are phagocytized faster. There are many publications to that effect. Once the extruded disc is in the epidural space, the results of phagocytosis and the body taking care of it are better as compared to a disc which is not sequestrated. So I would still be reluctant to operate a patient if just for a mild neurological deficit. The only emergency in my mind is a presence of cauda equina, that is, the symptoms are bilateral. 1, there is pre-existing canal stenosis. 2, and 3, of course, the patient is just not able to bear the pain. But I rarely have come now with so many medicines available. Very rarely you'll come across a patient who's going to agree to you for surgery for pain. The interesting part is that once the patient comes to know about the natural history and he's explained the correct evidence, he is going to take a choice of not getting operated. In our kind of setups, what happens is that the patient leaves it to you. He says, whatever you do is best for. We are not like in Germany or in the UK, where the patients are have access to evidence, or they are very searching for evidence. Our patients, they'll put it on us, and it is important for us that we make the correct choice for them.
Yes, sir. Very well said, sir. Thank you very much.
Can I ask you a question, please, if that's okay?
Yes, Naren.
Thanks. Dr. Patkar, what's your thoughts about epidural injections, caudal epidural injections, even after 6 weeks? Only anecdotal. I had a couple of patients when I did spine, and I had given caudal epidural injection, quite large discs on a young patient, and honestly, it was very much, and it was more to keep the patient pain-free until the operation, but the disc disappeared. Do you think the disc disappeared anyway, or do you think it's due to the caudal epidural injection, the steroid and the local? Thanks.
I don't think the steroid has any role in making the disc disappear. The steroid has got a role in making the inflammation subside. And I would, between the two, what I have found is that using the injection in the foramen gives better relief. Going and giving the injection in the Camden's triangle below the root. I don't like to use the supra-root technique. I give the infra-root technique, like the one we do while doing a percutaneous endoscopic discectomy, and injecting the steroid just near the much below the pedicle, but above the disc. I find that is better than giving it in the caudal epidural space, because in the caudal epidural space, a lot of that steroid is going to go onto the dorsal surface, where the disc is on the ventral surface.
Thank you, sir. Thank you.
Thank you very much, sir. Thank you. It was a very excellent presentation.
Thank you, Dr.
Okay, should we move on?
Yes.
Or there are other further questions?
Yeah, you can move on. We can move on. Thanks. Thank you, Dr.
Also, good evening from my side. My name is Van Ringelaar from mine, since Naren already introduced me. First of all, I would like to thank Naren for the invitation to moderate this and to be part of this. It's a pleasure for me. So the next speaker is Dr. Kiri from Morgantown, West Virginia. She is an orthopedic surgeon, and she's going to give a presentation on a very important topic where we see more and more cases in the recent decade, I would say. Title of her presentation is Discitis and Epidural Abscess. Are you here, Dr. Kiri?
Yes, hello. Can y'all see me?
Yeah.
Yeah, we can hear you.
All right. Wonderful. Let me get this sucker working here.
Dr. Patkar, if you can stop the sharing, then maybe Dr. Kiwi can upload.
Yes, let me try that again.
Dr.
Watching
Patka,
it.
Dr. Patka, would you be able to
Yes.
stop sharing then, Dr.
How do I do that? I have to stop sharing the screen,
Yes.
huh?
There should be a red button somewhere there.
Okay, yes, I've done that. Thank you.
Thank you very much.
Thank you. All right, let me try to
Right,
do
right.
that again. All right. Can you all see this?
Yep.
Yeah.
All right, perfect. Hello, I'm Shari Sui. I'm assistant professor of orthopedic spine surgery at West Virginia University, and I will be talking about discitis and epidural abscesses today. Oh boy, this is not working all right. Hey, Naren, when I share my contact on previous presentations, I'm able to share the actual program. So are you guys able to see that, or are you seeing the Zoom screen still?
At the moment, Zoom screen, but we saw your presentation about 2 seconds ago.
Yeah, but that was not loading up correctly. It was loading up a PDF version that didn't have all the actual text.
Okay. Whichever is easier for you, that would be fine.
Hmm.
You have the PowerPoint version or the Keynote version?
Okay, I have no idea what's going on, you guys.
We saw it like 2 minutes ago. We saw a version of your presentation.
Yeah, but it was kind of a bare PDF with nothing actually.
You have to share the screen. Are you sharing the screen?
I'm trying to share screen, but there's no option to share screen for me.
There is a green colored button at the bottom. You go to the bottom row next to the chats. There's a green colored button called share screen.
Yeah, I see that. It says share content. I don't see share screen.
Okay. Okay. If you okay, what
I'm using the app, so
if you click on the, is there a green button on your screen somewhere?
there is, and it says share content, but it doesn't pull up applications to be able to share screen.
Okay. Do you want to send me the PowerPoint on this side? I'll put it up.
It's a big PowerPoint.
Okay.
Let me try one last.
Yes.
The problem with this is it's actually missing a bunch of text in here, but I will give it. Let's see what happens. All right, you guys. So spinal infections are serious problems that all of us struggle with throughout our careers, and they're associated with high morbidity, mortality rates, and are expensive problems to deal with. The infection may involve the disc space, such as the left image there with discitis, the bony vertebrae there in the middle, that being bony osteomyelitis. And though the great majority of the time is a continuous spectrum of both, many of us will roll these into one term, that being osteodiscitis. Now, epidural abscesses, on the other hand, are infections within the spinal canal. This term can be confusing. The classic term generally refers to dorsal infectious collections in the absence of discitis or osteomyelitis. However, osteodiscitis can also extrude infectious material into the ventral canal and therefore cause neurologic compression. So a clinician should be clear as to which they are referring, whether it be a dorsal epidural abscess with a higher incidence and greater acuity and severity and presentation, or the latter. So infection can get there in several ways. Great majority is thought to be of hematogenious spread from a remote source, such as pneumonia, remote cellulitis. However, a good many can result from postoperative infections, adjacent tissue infections, and to a lesser degree now, direct penetration and inoculation, such as discography or injections. Risk factors include IV drug use, which is rampant in my part of the world, unfortunately, and diabetes, which is also rampant here. Dialysis patients, and any sort of immunosuppression. The process of bacterial osteodiscitis typically involves seeding of a relatively avascular disc, usually from the metaphyseal region, followed by extension into the adjacent vertebral bodies, and then in severe untreated cases can result in pathologic fracture and kyphosis. Now, on the contrary, Pott's disease, granulopatous infection caused by TB tends to spare the discs, and kyphosis is a hallmark of this disease. And a part of the slide that this cut off, fungal infections also present abnormally with a more indolent and fluctuant course, and is more often found in drug abusers and immunosuppressed patients. So with osteodiscitis and its involvement ventrally in its appearance, it can also resemble tumor or degenerative disc disease, such as motor changes, especially early in disease. Epidural abscesses, on the other hand, is thought to most often occur from hematogenious seeding of the dorsal epidural space, though it can also result from local or regional extensions, such as ventral infections. The space is generally without boundaries, so once the infection gets there, it can extend all the way from cervical spine down to the sacrum, but typically involves about 3 to 5 contiguous levels. The culprit organism is usually a staph, and in our unpublished study so far in our patient population, the dorsal epidural abscesses and neurodeterioration were highly associated with uncontrolled diabetes and significantly elevated blood glucose on presentation. So the course of these two infections can be very different. Both are characterized by back pain, and osteodiscitis tends to be a bit more indolent in history, characterized by multiple ED visits for back pain complaints and negative radiographs over and over again. And eventually they get an MRI and were consulted. The epidural abscesses, however, can have a similar history at some point in their history. But at our institution, once they present with an abscess, they tend to present acutely, more acutely at least, with a higher incidence of sepsis, neurodeficit fevers, and chills. So this here is the presenting MRI of an acutely paraplegic injection heroin user transferred to our facility 2 days after the onset of progressive weakness, and she was ASIA B on presentation. She was emergently decompressed, ultimately regained ASIA C function before she was then lost to follow-up. So initial workup of these patients should comprise the routine labs such as inflammatory markers, CBCs, cultures, and also in the hands of my medicine colleagues, they'll also look for systemic illnesses such as hepatitis, HIV, and other immunosuppressed conditions. Imaging should be obtained when suspicious of spinal infection. That really includes an MRI, that being gold contrast or gold standard to diagnose this, with and without contrast and upright radiographs. CTs are also beneficial, especially for preoperative planning, to evaluate the amount of bony destruction. So radiographs, you can kind of see the natural progression there. They tend to be early negatives in the disease. However, as the infection continues to roil, end plate destruction will then be seen. Infection extends into the vertebral bodies. You can start seeing that collapse and kyphosis develop. MRI findings then tend to be hyperintense or equivocal on T2s, hypointense on T1s, and the infection typically enhances very brightly on gadolinium. The findings involve the disc and the surrounding structures, much in many of the cases. However, contrasted tumor, typically a tumor spares the discs, whereas infection usually does not. Upright X-ray should be obtained to evaluate the functional stability of the spinal column, and CT scans are useful for preoperative planning to evaluate the quality of remaining bone stock. Now, epidural abscesses that present acutely with neurodeficit or sepsis are treated surgically, period. But in early cases found in neurointact patients, antimicrobial treatment is often sufficient. And at our facility, we tend to do 4 to 6 weeks. However, there have been Research showing anywhere from 2 weeks to longer than that, depending on the bug. Surgical treatment for epidural abscesses. When surgery is necessary, focal abscesses can be evacuated with decompression alone. Longer spanning dorsal collections, I typically treat with multiple skip laminotomies, and that spares the midline structures and kind of precludes the need for instrumentation in my mind. So what I do is with these multiple skip laminotomies, I target the side where the abscess is, and then I string a pediatric feeding tube from one laminotomy to the next, suctioning and evacuating the abscess. Sometimes I irrigate, but this should be done with caution. You don't want to squirt a ton of fluid into a relatively closed space. So when I feel it's necessary, I'll usually string 2 very small feeding tubes adjacent to each other, one aspirating and one irrigating. Now, the treatment of osteodiscitis is a bit more nuanced than that. The mainstay of treatment is still antimicrobial therapy based on causative organism. And this can be identified either on blood culture or IR-guided disc aspiration and core bone biopsy. Now, I'm not sure about anywhere else, but at our facility in the United States, our patients tend to come in already flooded with empiric antibiotics given by the outside hospital, the primary team, or whatnot, even in non-septic patients. So blood cultures are often negative and unreliable for us. IR biopsy then is another means of obtaining a culture positive organism to direct the medical treatment. Surgery for osteodiscitis then is indicated on top of medical management when the patient is septic or suffering progressive neurodeficit, and I do not count painful radiculitis in this. Painful radiculitis tends to improve, and that's just from the inflammation and irritation of the nerve root surrounding the infection. So surgery is also indicated in a less acute patient when there is fracture, kyphosis, or when they fail medical management. And the definition of that can be debated for quite some time. So the goals of surgery is to decompress, debride, correct abnormal alignment, and stabilize when necessary. In the patient with normal alignment and uprights that are stable, limited decompression debridement is often enough. In the presence of instability or listhesis, I tend to add posterior instrumentation to that. And when kyphotic, that frankly means the anterior column is no longer adequate. The anterior support is then necessary. So the one thing I've learned in training and supported with my practice is that infection loves instability. So obtaining stability with surgery when necessary, it's absolutely paramount to infection resolution in my eyes. So this is a case of my gift that never stops giving. This is a 40-year-old female, intravenous methamphetamine abuser, transferred with severe kyphosis and left arm weakness after failed anterior treatment at an outside facility. She presented medically stable and ambulatory with no other neurodeficits. Yeah, can't kill a meth head. These are the images preceding her presentation to me, and her presenting CT there is last on the right side. So I put her into traction, and thankfully she corrected. There was no changes in her neurology, and then we obtained a CT. MRI was god-awful quality. Medical optimization was also started at this point, and I would like to harp on this because I think it's what saved us on her. Many times these patients come in significantly depleted nutritionally as well as vitamins in every other way. So we have a team that is put into place that helps us medically optimize all these complex patients that require front-back significant surgeries. This is her CT scan. So you can see there's severe bone loss in 5 vertebral levels and bilateral facet discongruity and frank absence on one side there. I planned a staged procedure and I chose to go posterior first. And the reason for that really is I don't trust my meth heads. So I did a posterior instrumentation, fused her from C2 to T5, placed her in a halo to try to keep her from leaving against medical advice. She has a history of this. So with this improved alignment, locked in, I was then able to buy some time. I got my preferred ENT surgeon available for the anterior stage and got a CT angio. She was narrow intact the whole time, at least narrow stable the whole time. She still had that left arm weakness. But as you can see on CT angio, this woman has retrograde only flow through her vertebral arteries. So you can see her arteries teetering out there at C5, and they're absent by C6, C7. No stroke symptoms throughout her stay. These are very resilient creatures. Second stage of the procedure was anterior. A couple days later, with my access surgeon available, I performed, anterior hardware removal, 5-level corpectomy with reconstruction. She was very small boned. I didn't have enough room to inset the cage to prevent kick out. And this is the smallest mesh cage we have in that length. So I placed 2 small kick plates to prevent ventral displacement of this massive strut. Story doesn't end. IV antibiotics for 4 weeks before she left against medical advice in the halo. She no-showed for months and then returned 8 months later with her halo still on. Spine is fused. She returned for pneumonia, also found to have fulminant liver failure, a 2-centimeter long tricuspid vegetation, in addition to her pneumonia. And then she left AMA with all of that. Those are her pin sites that are cut off there. And then she came in 3 months later after the removal of the halo and everything else. She was doing drugs on the railroad tracks when she fell and sustained a C1-2 dislocation. Walked around home for 3 days before her left side started to get weak and presented to the ED. I extended her to her skull, and then she left AMA again 1 week later. So she eventually returned months later with multifocal infections involving multiple musculoskeletal sites, from her SI joints to her sternoclavicular joints everywhere, and viscera, and left AMA before she was placed in hospice, still in liver failure, still with that massive vegetation. So spinal infections are serious problems. They have high morbidity and mortality rates. The patient population is difficult, if not medically, then socioeconomically. Treatment mainstay continues to be culture-directed antimicrobials plus or minus surgery. And surgical stabilization approach should be tailored for the patient's pathology. There is no single right answer. But that also means that we're able to be our most creative in these complex cases. And also I learned that you can't kill a meth head. Thank you. Any questions?
Okay, thank you very much. Very nice overview, very nice presentation, extensive surgical case. Thanks a lot. So you mentioned 6 weeks antibiotic therapy. Are there any cases where you would extend the antibiotic treatment to 12 weeks, giving it for 3 months? Because in my practice, I use it almost as a standard. I know that uncomplicated spondylolischitis can be treated with 6 weeks, but the case I do surgical is for me in most cases a complex case, and therefore I go for 12 weeks.
So I think my opinion in terms of the antimicrobial therapy, the evidence is everywhere. It goes from anywhere from 2 weeks for epidural abscesses to 6 to 12 weeks for complex osteodiscitis. At our hospital, we have an outpatient infectious disease service that actually manages this, and they base their duration. They start at 6 weeks as our standard, and we extend it based on response from ESR-CRP. One thing I don't like that they do, unfortunately, is they also image the patients using MRI imaging to say if something has resolved. However, as surgeons, we all know that by 6 weeks, imaging half the time looks worse, right? Even though symptomatically they are better. So I leave it up to our guys, but they tend to start at 6 weeks and then prolong if the ESR-CRP is not improving. I see them throughout, and I would recommend reimaging here and there, look for other sources if it's not improving much at all, or if their pain is not resolving after a few weeks, actually, sometimes I would consider that as a failure of treatment if there's no other sources found. So that's kind of that's a can of worms question.
Okay. Are there any further questions? Darren, do we have anything coming in? I got one more point. Well, we from time to time we see those cases where it does look like a discitis. It might also be a degenerative change of the T2 images where the disc lines upright. How often do you go for a disc biopsy, and how much do you rely on the disc biopsy, and where do you look for contrast enhancement and try to get exactly the point of contrast enhancement before you go for a decision of going for surgery or not in a patient with back pain, not real CRP elevation, those complex cases where you're unsure what it is?
Yeah, so those, I use ESR-CRP. If those are absolutely negative, honestly, I'll probably just watch them symptomatically, reimage them in a few weeks to see if it's progressed. But we also have patients who are renal patients on dialysis, and they have persistently elevated ESR CRP and also back pain forever. So it's hard to track those. So really, IR biopsy and core biopsies are go-to for the ultimate answer per se.
Okay, good.
There's a question from, I'll just try to get Dr. Patkar.
Yes.
There's a question from Dr. Patkar. I'll read it out from the chat box. Is bed rest mandatory when antibiotic therapy is started to prevent deformity, anticipating instability?
We actually don't use bed rest at all in these patients unless they are acutely unstable, similar to this case I presented. So for those with upright stable x-rays, we don't even use braces because there's really no good literature to show that even bracing prevents any kyphosis development. I think it's going to happen with the infection. If it's going to happen, it's going to happen, bed rest or otherwise. It's a whole cascade of inflammation, destruction, bony erosion. If it's going to happen, it's going to happen. That's kind of an indication of whether or not medical treatment is succeeding. So I don't think bed rest is mandatory, in my opinion, no.
One more question from Dr. Javier. Does the duration of antibiotic change if there's a metal used?
It doesn't change in my hands. Now we routinely use titanium, both for the biofilm literature and everything, but in my experience, more stability with instrumentation has actually helped, at least in my practice. I've not yet published that. I'm working on it. I'm only 5 years in practice, but based on both how I was trained and what I've seen so far, instrumentation helps in those with instability. It doesn't necessarily prolong the duration of the infection.
Thank you, Dr. Professor Ringer. That's all the questions from this side, from the chat box.
Okay, I have one more short question. You just mentioned you use titanium. Do you use any PEEK implants, PEEK cages in infectious cases? Or would you say this is a no-go to use PEEK?
You know, we've all taken out those PEEK cages that are post-surgical, infected or otherwise. They don't look like they've integrated at all into bone, and now they're covered in pus. So it's a personal flavor, but PEEK is a dirty word to me. So, that's where I go back to my training, unfortunately.
Okay, titanium screws and titanium cages. Okay.
Typically, yes, or allograft. Yeah.
There's
Good.
one more question. Sorry if that's okay. It's quite an important one, I think.
Yeah.
Is that okay, Professor Ringer? The question is that, did you face any case complicated with infection of the metalwork as a consequence of the primary spinal infection?
Not yet. I'm 5 years into practice. Unfortunately, a very high proportion of my cases are infections because there are a lot of meth heads and intravenous drug users here in West Virginia. But I have not yet had any secondary infections of my instrumentation. I have had other sites in the same person, such as this patient with cervical. I eventually had to do a lumbar as well. But no, not same site recurrence yet in my practice. It will happen. I'm waiting.
What's the proportion of multi-resistant bacteria, MRSA, in your practice?
Oh, the proportion of it?
Yeah.
Gosh.
Is it few, or do you see it on a regular basis, like complex germs?
I would say at least half are staph species of some sort. Usually, actually, we have MSSA, but probably a quarter of them are MRSA. It's a high proportion here.
Okay. Okay. Thank you very much. Very, very nice presentation. Good discussion. Thanks.
Yeah, sorry it didn't work. Thank you, guys.
That's
fine. Fantastic.
That's okay. Good. So we move on to the next presentation. It's the Dr.
Komal, do you want to?
There's some more questions in the chat box. If Dr. Sui can reply to them in the chat box, it will be very helpful.
Dr. Sui, there are some more questions on the chat box. If you have time, I appreciate if you can answer them on the chat box, please.
Thank you.
Great, thanks.
Thank you. So we'll go ahead with the next presentation. The next presentation is on intramedullary spinal cord tumors by Professor George Jallo from St. Petersburg. you all know, he's Medical Director, Chief of Pediatric Neurosurgery at Johns Hopkins All Children's Hospital at St. Petersburg, Florida. Welcome, Professor Jallo.
Well, thank you, Dr. Prasad. Thank you, Naren, and thank you for everyone for participating today. Just trying to get the slides up. As we said, I think what I'm going to talk about is really intramedullary spinal cord tumors today. If there are any questions, just please try to stop me. I'm happy to answer them. Can everyone see the presentation?
Yes.
Great, and I have no disclosures. So I think, when we talk about spinal cord tumors, and this presentation today, really want to just give some up-to-date logic, thinking processes about the management of intramedullary spinal cord tumors, the goal of the surgical intervention by the entity, discuss a little about neurophysiology, neuromonitoring, and then really discuss the surgical procedure for the resection of a spinal cord tumor, and at times discuss the outcomes and prognosis for these tumors. So when we talk about spinal cord tumors, I think one, we all recognize they're rare, they're extremely uncommon. And when you look at this pie chart here, the spinal cord location accounts for less than 4% of all central nervous system tumors, whether they be both benign or malignant. The entire entity in it itself is extremely uncommon. Depending upon the location, could be 1 in several hundred thousand to 1 in a million that one may see an intramedullary spinal cord tumor. The good news is the majority of them are going to be benign. Bad news is the location is high real estate and it is extremely difficult to operate on these. The malignant tumors, depending upon the series, and I've seen it anywhere from 15 to 20%, but over 80% will be benign. Metastatic tumors are extremely uncommon to the spinal cord. I'm not sure why, but it is. I can say of the over 500 spinal cord tumors, I'd say less than 1% of those intramedullary tumors were metastatic tumors to the spinal cord. So, when you see that presentation, it's extremely uncommon. In adults, we're going to talk about ependymoma being the most common. In children, less than 18, it's really the astrocytomas, the grade 1 and the grade 2 tumors are more common than ependymomas. And now, in terms of management, there's still controversy. Who do you observe? Who should undergo surgery? If they're going to undergo surgery, what is the approach? A biopsy, a gross total resection, or somewhere in between that. Radiation therapy, are we going to use conventional radiation therapy, proton beam, or are we going to use stereotactic radiosurgery, given the advent of the cyberknife and all? And then chemotherapy agents, what is used? So when we look at some, again, as I said, when we look at general facts, as I said earlier, it's 3% children are more likely to have a spinal cord tumor than adults. And the adults, 50 to 70% is going to be the ependymoma, whereas 40 to 60% will be the astrocytoma. Intramedullary hemangioblastomas, isolated or with von Hippel-Lindau, account for about 5% of these tumors. And then another 5% will be the miscellaneous tumors, the gangliomas, the mixed gliomas, or some of the other entities. And as I said earlier, metastatic tumors are extremely uncommon, and there's a reference there for that. When we look at that, by around 30 years of age, that's when the ependymomas slightly become more common than the astrocytomas, and then they predominate in the middle decades of life. And however, after 6th decade or 60 years, you can have both an equal presentation of astrocytomas and ependymomas in adults. Looking at the two main players, ependymoma and the astrocytoma, really, it's typically the cellular ependymoma could occur anywhere in the spine, equally cervical versus thoracic. The myxopapillary is included in this, and I think that's a mistake. Those are really a different it's a different beast, a different animal, and I'll share a slide or two on that. Mean age is about 43. There's some cystic degeneration of these tumors in over half the time at presentation. You may see hemorrhage or hemosiderin staining, a cap sign, and you'll see the diffuse cord enlargement at multiple levels. And the good news is these tumors have a sharp delineation from the cord and have a good resection plane. And typically they're homogeneous enhancing and typically located centrally identified tumors in ependymoma in an adult unless otherwise stated. On the other hand, the astrocytomas, as we said, majority are going to be low grade. You can see grade 3 or grade 4 astrocytomas in both children and adults. Typically, mean age is 21 years. They are cystic, less likely to hemorrhage, tend not to show hemosiderin. Again, will have the diffuse cord enlargement, much more infiltrative with a less defined plane, especially for the 2, 3, and 4 versus the grade 1 polycytic, and they too can be heterogeneous. The key point is here, they're heterogeneous and eccentric. Your ependymomas are homogeneous and centrally located. You see on this slide here, this hemosiderin capping here. Again, that is suggestive of an ependymoma, and you can see some edema extending above and below the tumor. The ependymomas are typically classified in WHO classification as a grade 2. You can see on histology, the elongated cell, classic features. Let's be honest, it's shocking that this tumor, if you showed this histology to any pathologist without any of the surrounding tissue, normal tissue, spinal cord or brain, they can now tell if an ependymoma arose from the brain, posterior fossa, or the spinal cord. Anaplastic ependymomas, uncommon, again, less than 3% of all ependymomas will be grade 3 with anaplastic, and these are typically have increased cellularity, more mitoses, necrosis, and more frequent pseudorosettes as compared to the more common and less aggressive variant. When we talk about these astrocytomas, again, the astrocytomas are identical to intracranial astrocytomas when you look at them histologically, grade 1, 2, 3, and 4. Some of these intramedullary tumors do have chromosomal changes that are not typically seen in the intracranial location. However, this is more common in children than adult, and the genomic changes are more common in the adult. And you can see this as a infiltrative tumor in the lower cervical, upper thoracic from C6 down to about T2, 3, with enhancement, very little enhancing, but diffuse enlargement. And you can see on histology, this was a grade 2 astrocytoma. The anaplastics imaging tend to look the same. However, they may be associated with more edema or swelling above and below. It's only on histology that you get to see that they have more cellularity and more vascular proliferation. And for your glioblastomas, if you look at this one here, again, on this T2, you can see the extent of the edema extending above and below, and histologically, much more aggressive features with mitosis, necrosis, and the vascular proliferation. The myxopapillars, I want to just share one slide. It is a grade 1 tumor. I think that's where even with our histology, we fail in terms of recognizing these. These are typically the most common intradural tumor in the conus cauda, and again, more common in adults than in children. You can see the phylum here, the well-circumscribed tumor, as well as histology. A WHO1 tumor, yet these tumors have a higher propensity for dissemination and recurrence as compared to your intramedullary ependymoma, which is a WHO2 classification. Gangliomas can be both benign and anaplastic, as seen here. And so let's talk about the symptoms. Spinal cord tumors, as I said earlier, majority of them are going to be benign. They exhibit indolent growth, and they're very slow and progressive clinical symptoms. Thus, there's a long delay in the diagnosis, which is common. And the most frequent symptoms could be pain, typically axial or neck pain if it's a cervical tumor, could be occasionally radicular if there's some nerve compression, and typically nocturnally at night. Typically we'll wake up or the person in the evening or when they lay flat, and I think more likely as an obstruction of the CSF as well as the diurnal variation of the steroid production. And when we look at this, there have been several papers that looked at the reported duration of symptoms. Typically, it's on the order of, the mean is around 9 to 11 months, somewhere between 8 and 17 months. Higher grade tumors are going to have a shorter duration. I think that's the key. Always listen to the patient. If they're presenting with a very rapid and short history, it's not your typical benign tumor. It's something else, whether it be a high-grade tumor or some inflammatory process. And when I look at that, if I'm unclear in the evaluation, rather than rushing into surgery, I will wait a couple weeks and repeat the imaging just to see if there's been any changes. And for me, the reason for that is if it's a low-grade tumor, it's unlikely to change. If it's a high-grade tumor, delaying the intervention is not going to change the final outcome given the overall poor prognosis for these malignant intramedullary spinal cord tumors. And if it's an inflammatory process or something else, you will see some change. And when I say repeat the scan, it's a very short interval. Typically, if I'm uncertain, I'll repeat it in 4 to 6 weeks, consider a spinal tap, consider imaging of the entire neuroaxis. So, when we look at the experience, the surgical experience, it's been written about as early as Ellsberg in 1911. They recommended a 2-stage technique, laminectomy, do the myelotomy, close them up, maybe a duroplasty, and then come back 7 to 10 days later, and you'll see a tumor being extruded out of the spinal cord, and then you shave it flush to the dorsal surface of the cord and remove that and not go into the spinal cord. In the 70s, there was no attempt to do the myelotomy or procure a biopsy given the complications. We know that Cushing operated on these, and he found that there was some satisfaction in operating on some of these tumors, especially the ependymomas, which he described it as a ripened banana during the removal of these intramedullary tumors. So, in terms of old school management, it's really, there's been controversy and some resistance to change. The traditional approach has been just a biopsy, laminectomy with or without the dural decompression, radiation therapy. And however, knowing that the majority of these are low-grade, indolent, and what we do know in the brain is if this was a low-grade tumor in the brain, no one would hesitate to go in there and try to achieve a radical or gross total resection. So if for these tumors, that being benign or low-grade, the goal is really a radical resection, and there's been many advances in the technology as well as in the neuromonitoring and the equipment that are available to us. The other is we do know for these, and it's many surgeons have previously published it, the better the patient is at time of surgery, the better they will be in the long-term outcome. Taking a patient that is in a wheelchair, doing a great operation, resecting it completely, is unlikely to make that patient walk again. So if you're going to take someone that was ambulatory, walking, wait for them to be in a wheelchair before you operate, you've missed it. It's too late, far too late to do that operation. Here's an example. This is a 25-year-old woman presented with some urinary urgency and incontinence. She was found to have scoliosis and hyperreflexia. What's the differential diagnosis? What's the treatment paradigm? And what is the role for surgery? You look at this on this T1 with contrast, you can see a large tumor from about T6 down to T11. You can see the expanded cord and the heterogeneous enhancement. And you can see that there is a mild degree of scoliosis already. And she underwent an osteoplastic laminoplasty and gross total resection of her tumor. It was a grade 1, a juvenile polycystic estratoma, probably been there for years, ever so slowly growing until she developed her symptoms. And she is 14 years out and has had no other treatment. She did require a stabilization procedure to correct her scoliosis, but short of that, She's been tumor-free and gets scans every 2 years just to follow it. Here's the next case. This is a 46-year-old gentleman presented with a long history of right shoulder pain, had a biopsy in 2013. Again, just pain in 2013. The tissue came back non-diagnostic. He was watched for less than a year, and he presented in the wheelchair with increasing pain and right side weakness. You can see the previous laminectomy here on this T1, T2 with and see all the, whether it's tumor infiltration or edema that's extending up. Here it is on the contrast, the previous laminectomy that was performed and the enhancing tumor. And again, being non-diagnostic, no other treatment, no chemotherapy, no radiation. He ends up in a wheelchair, essentially. Although I said the biopsy was done in 2013 elsewhere, he ended up in a wheelchair in about 4 months. And when I saw him, the goal of surgery was to get tissue and not in some decompression. This, here the contrast and the T2, that turned out to be a glioblastoma. And even with radiation therapy, he survived. He did succumb to his disease at the end of the year of 2014 and within 9 months. So when we look at this, when we look at the extent of resection for astrocytomas in adults, and what we do know is that the low-grade survival for a adult intramedullary spinal cord tumor, whether it be a grade 1 or 2, the 1-year survival, if nothing is done, is 80%. With a near total or resection, it's 100%. 5-year survival is significant if without without any treatment versus a gross total resection, you gain close to 5-year survival of 95%. The high grades, you can see that doing surgery, whether it be a partial, a gross total resection or not, minimal treatment, the survival is not good for these tumors in the long run. And here it is on the Kaplan-Meier curves, looking at the extent of resection and the biopsy or no treatment. So the goal is, radical or gross total resection whenever possible, except for these high-grade tumors. And we did look at this several years ago, the poor prognosis, despite aggressive treatment in adults with intramedullary spinal cord glioblastomas, and we did find a very little difference with surgery. Looking at 230 patients that were done at Hopkins, looking at this, the majority, 60% were adults, a third were children. The duration, as I said, as was been previously ran, durations 17 months. Close to 2/3 will have some motor deficit, sensory deficits, and half will have pain. Some bladder dysfunction and gait instability will be about 20%. Majority did have some previous treatment before coming. And in terms of the functional McCormick class or the Asia impairment scale, you can see that close to 85–90% were in a McCormick 1 or 2, or you can see the ASIA's classification, close to 92% were D or E. And involvement, it's typically, they're short, about 3 levels, location equally distributed between cervical thoracic locations, and then whether there was enhancement or not. And just really, these were the diagnoses. Ependymomas accounted for half, astrocytomas for about another 40% of these. It was a grade 1 or 2, and your anaplastics or GBMs were uncommon, hemangioblastomas and gangliomas. When we looked at the overall survival, we looked, it was at least 30 months. Some had the resection, some required chemotherapy, radiation therapy, and close to 20% did show some disease progression, and death occurred in 13% in the high grades. What were predictors of the resection? Gross total was, if they had no preoperative symptoms, tumor edema was an independent indicator of outcome, and then the ependymoma, as one would expect with the good cleavage and tissue plane. Looking at the progression-free survival, looking at that, when we looked at this, median progression-free survival was close to almost 10 years, and no previous surgical resection was an indicator. The ependymoma, as one would expect, and low-grade tumors as compared, and looking at the postoperative symptoms. And let's just jump down here. You can see, your ASIS impairment score still, after surgery, close to 85% are a D&E. And if we looked at the McCormick functional classification, going from about 85% to about 75% are still 1 or 2 after surgery for these. Here's the key. Here's the slide. Improvement in terms of motor, bladder, and sensory. Looking at these patients, you can see that the motor function is going to continue to improve up to 2 years. Bladder function will improve up to 2 years as well. And your sensory, whatever they have at about 6 to 9 months is what they're going to be left with. So I think, we always say these people can improve 12 to 18 months. What we did found sensory will plateau earlier than you saw in the other functions. So how do I do these tumors? Typically, all prone, the cervical thoracics, I'm going to place in a 3-pin Mayfield head holder, try to maintain mean arterial pressure, make sure bony protrusions are well padded, have the neurophysiological monitoring. And I want to, as I open, I'm really thinking about the closure. You can see here, planning the incision, the laminectomy. I tend to do an osteoplastic laminoplasty. I used to use the Midas Rex drill. Now I use the Misonix or the bone scalpel. Plate them back with mini plates and hold the bone back and try to elevate it up. I use both sensory and motor evoked potentials, both muscle as well as the epidural D wave, and really want to monitor during the resection. This was an ependymoma before. You can see expanded cord, and this is it. Here's the tumor, and this is after the resection of the tumor. And what we do know about neuromonitoring, and we'll try to skip around here, really use both the muscle as well as the epidural D wave, past an electrode caudal. And this really electrode is not influenced by the blood pressure or heart rate or some of the inhalational anesthesia drugs, and looking at the amplitude of a single wave of the corticospinal tract. And there's the references for that for you with regards. And this is, what we do is with the epidural D wave, we pass a caudal. We do a single stimulation of the motor cortex, get this wave, a single wave of the corticospinal tract, and then we watch the amplitude in the muscles, the end organs, whether it be in the upper or the lower extremities. We fire an action potential, stimulate 4 times, fire the action potential, and see whether or not this wave is present distally. And using both, the epidural as well as the muscle recordings, all or none. This is really, I'm going to just go through this. As long as the amplitude of that epidural wave does not decrease more than 50% and there's no change in muscles, I'm going to keep going, expect no change in the outcome. If there is, again, no change, less than 50%, if there is a loss, I'm going to continue pushing it and expect a transient motor deficit. If the amplitude of the D wave is lost more than 50% and there's a loss of the muscle, there's a permanent and deficit, and probably should have stopped before that. And I think this just color codes all that I just said earlier. I think, in terms of how do we know how far, use the X-ray to localize, and then really use the ultrasound after the laminectomy, before opening the dura, just to make sure that we've gotten the tumor within the limits of the bony opening. The myelotomy typically is done in the posterior median sulcus or the dorsal median sulcus, but you can do it in the intermediate sulcus or even in the posterolateral sulcus for some of these eccentric tumors. You can see here the vessel that we are shifting, and we're doing the myelotomy here with a sharp, whether it be arachnoid knife or this. I actually use a 16 gauge spinal needle for the myelotomy. Try to minimize the cautery until after the myelotomy has been opened. This is a dorsolateral. You can see the nerve roots here to approach this tumor. And then expand it. I don't put in PL traction sutures, and that's controversial. I like to use these plated bayonets. They retract where I'm working, and it allows the spinal cord rest elsewhere. So I try to, again, with the idea of limited traction on the spinal cord, especially when it's compromised with a large tumor. And you can see here, after tumors removed, we just inject some Avitine Flow Seal, irrigate this out, close the dura in a watertight fashion, I put some tissue glue over it. I will return the lamina and close it in a watertight fashion. I typically, they're in the ICU, especially for the lower thoracic lumbar tumor, they're flat for 24 hours. If they're mid-thoracic and up, I typically keep them head up. I taper the steroids that they've received in about 7 to 10 days. And patients, if they do awaken with a transient motor deficits, and if you're using neurophysiological monitoring, I'm very confident in that, and will not do the imaging until the following day with an MRI. I typically get MRIs on all my patients with tumors on post-op day 1 and try to confirm that the extensive resection was completed. So in terms, hopefully I've stayed in time. I do want to thank you for this opportunity to speak virtually on Zoom, and want to thank Naren and Dr. Prasad for allowing me to present on my experience with intramedullary spinal cord tumors. Thank you.
Thank you very much, sir. Very nice elucidation of the common pathologies and the elaborate discussion of the surgical aspects and post-operative care. So I have a question. Like when we see the Kaplan-Meier graph of gross total resection versus decompression versus no surgery, I will get a feeling like, the extent of surgery, extent of resection is determined by how infiltrative the tumor is and whether we get a plane. So the resectability of the tumor and the tumor biology plays a role rather than the surgeon's skill in actually taking out the whole tumor as it is, because the surgeon will have to make a decision whether he will be able to take it out depending on many factors, whether there's a drop in MEP or whether there's a plane or not. So isn't it biased to say, like in a graph, that gross total resection gives a better outcome?
So yes, I mean, I think if you can see from there one or two of the slides, you know, we were able to achieve a gross total resection for tumors that had a very good plane, and that's typically your ependymomas, and sometimes your grade 1 astrocytomas, which have a plane. So extensive resection was guided. Really, we're able to achieve a gross total resection with your ependymomas, more likely with ependymomas which have a good tissue plane than your infiltrative tumors. I will be aggressive even with my grade 2s and, you know, infiltrative astrocytomas if I know the neurophysiological monitoring is working. I will be much more conservative with the 3 and the 4s, even with neurophysiological monitoring, just because we found that the outcome doesn't change for the grade 4, grade 3s, anaplastic. The more resection, they do a little better than that. But correct, the plane, the tissue plane. Now, I will tell you, I will work out for the ependymomas. I try to, as you saw on that slide, I work the plane and try to get out and block. For the larger ependymomas, I will debulk them first and then work out the plane. I will rely on the monitoring to make sure I'm not pushing, pulling, or tugging too hard during the resection. Hemangioblastomas, vascular tumors, I don't, you know, I use the monitoring, but I don't rely on it because that's a tumor. You've got to get it all out. Otherwise it's just going to bleed. So it's good to have, again, just, how hard are you pushing on the spinal cord? Are you injuring it? Is there traction? But the extent of resection is really guided by the tissue plane and how easily it's coming out. There's a question about getting a frozen. I always do a frozen. You know, again, you really are dependent upon the skill of your pathologist and their experience with frozens, because I've been places where they've been completely wrong in terms of the frozen. I'm pretty good at predicting what the tumor is. If there's a good plane, you know, I suspect it's going to be an ependymoma. If there's not a good plane, then it's an astrocytoma. And I can tell you, majority of the time, grade 1, 2 look very different than a grade 3 or 4. So I do the frozens, and it doesn't change what I do, but what my plan is. The next question is, I try to do a laminoplasty for all my cases. I just find that it's more physiologic. I mean, I've looked at the papers. Does it prevent progressive kyphosis? Does it prevent the need for corrective scoliosis or deformity surgery? No, there really isn't an outcome. What we did find with the laminoplasty, when we do return it, it was less likely to develop a CSF leak than if we did not put the lamina back.
So there are a few more questions. If you can be kind enough to answer those in the chat box.
Yes, absolutely. I think the next question was, the approach for multi-level tumors. It's a great question. I wrote a paper on holochord tumors and the role of aggressive surgery. And I'm talking tumors from C1 down to T10, T11. Typically, these were all low-grade astrocytomas, either grade 1 or a ganglioma, and we did radical resection and they did well. I think, in this day and age, with the complications that they have with deformity and everything, I think there's a role to do a limited resection, a resection of the upper, if they're having upper extremity difficulties, and then consider treating them with chemotherapy or radiation for the residual rather than doing a whole entire, C1 to T12 laminectomy for these. Intra-op methylprednisolone, I use dexamethasone. They all get dexamethasone at time of surgery, and then it's weaned over 7-10 days. I don't use the Solumedrol trauma protocol, regardless of whether there are changes in the monitoring or not. I stick with my standard of Decadron. I've seen, I think when you read the papers, there's really no good data on that on Solumedrol for spinal cord injury, and it only has more complications. If the MAPs are lost and the D wave is still intact, yes, I will continue and go ahead with the resection, all the while monitoring the epidural D wave during the resection. I tend, fixation, I don't want to say I never do it. It's been unusual for me to fixate or stabilize the spine at the time of resection. And the reason for that is I always want to do the resection, get one good post-operative MRI to ensure there was, whether it's complete resection or not, before we put instrumentation. So 99% of the time, I will not fixate at the same time, but there is the occasional time or at time to do that.
George, can I just interrupt, George? I think your talk has been popular. The questions have been growing by the minute. Is it okay if I just ask you if you could take 5 minutes and answer them on the chat box so they?
Oh, sure, certainly. I think that's great. I'll take care of it.
But can I please invite Professor Goel to make a comment, please? Professor Goel, can you?
No, Dr. Jallo, this was a great presentation, and I've heard you before on this subject. You constantly innovate and go further on this. I would just like to ask you one question. I know you might have answered this. What about the difference between low-grade astrocytoma and low-grade ependymoma? What do you see? How are they different, and how is the outcome different? What is the thinking process different in these two cases? You must have answered, but can you do that again, please?
Oh, no, I told that's a great question. Thank you for being here. So when I look at ependymomas in the low grade, the grade 1 astrocytomas, I look at them as the same disease. Ependymomas in adults, grade 1s in children. And my goal is to get a gross total resection, no adjuvant treatment, no chemotherapy, no radiation. And overall, I'd say their long-term outcome is essentially the same. You're looking at 10-year survival, progression-free survival of like over 92% for both of these tumors. So to me, a grade 1 pilocytic astrocytoma in a child and the ependymoma are the same disease, just in different age groups. The ependymomas tend to have a better resection plane, but the pilocytics, you can find that plane and you can work it and be able to completely remove it.
Thank you very much.
Thank you.
Thank you very much.
Thank you.
Komal, you're happy, Komal?
Okay.
Yeah. So thank you very much, Professor Jallo.
Thank
So
you.
there are a few more questions which you can please answer in the chat box. It will be highly appreciated.
Thanks.
Okay. Then we move on.
Yes.
Yeah, please, Dr. Florian.
We move on to the presentation. Presenter is Dr. Tim Rutter. He's Associate Professor, Department of Neurosurgery at the Penn State University. And he's going to give a presentation on cervical spine trauma.
Thank you. Thank you for the invite. Hope everybody can hear me.
Thank you. Thank you.
Getting used to Zoom. So I was tasked with looking at certain trauma cases and the controversies and different ways to treat them. I do have disclosure. I do consult for Sentinel Spine, but won't be talking about Protus C in this talk. So the controversies that I was asked to look at were clearance of the cervical spine in unconscious patients, management of odontoid fractures, reduction of set dislocations, and also have a kind of open discussion on the management of a C7 burst fracture. You know, there's not a lot of treatment standards out there. There's a lot of guidelines and there's some options. So we'll talk about that. And then I'll just kind of talk about my thinking as I go to treat these things, and comments, questions are welcome. So if we first talk about, I think this is probably the easiest one, cervical spine clearance in a comatose patient. Although it's easy, it's always, I think, a bane of all of our existence. So since the patient's unconscious, they can't complain of pain, there's no clinical exam, and it's not a weight-bearing study. You know, they're lying on their back. And one of the few standards that we have in spine surgery is that radiologic assessment is not recommended in a patient, asymptomatic trauma patient who's not intoxicated and doesn't have any distracting injuries and tells you they're fine. So that being the standard, we have that, we don't have that exam. So, you know, at this time, I think really high quality CT is, you know, very, very good at giving us an idea of stability. Doesn't miss fractures. You know, I don't think at this point many people use X-ray anymore. A negative CT, I think you can be pretty sure that there is no instability. I mean, there's some papers here I have listed that talk about that. That being said, though, I think you still have some options if you're worried about the mechanism or there's something that just, you know, you don't feel comfortable clearing the patient. You know, you always can get an MRI. And I think in that case, the biggest problem with MRI is just the false positives. You know, they just show everything. And when you get that information, you got to, you know, be ready to be able to act on it, whether you're going to use that information to say, look, we can't clear the spine, or say that that's something that's not important. Back when I trained, we did flexion extension x-rays under fluoro, but I think that's really fallen out of favor these days. And they were honestly, I don't think they ever worked out well to begin with, but I, you know, I think an MRI is something that you always have. And if you're, you know, if for some reason you have a suspicion that maybe the patient could have an unstable cervical spine, you should use it. You know, if the high quality CT scan does have a finding on it, then you need to treat the finding as if you would in any patient, right? If it's a spinous process fracture, it's probably not going to be unstable. I mean, if you're worried, you can get an MRI or something to see if there's any disc injury, but that's a patient you're probably able to clear. And then the other thing to think about is, you know, this patient, if they're paralyzed and stayed in the ICU, you probably can take the front part of the collar off when they're in bed, you know, if they're worried about ICP or something. And if they're going to transport patients, they put the collar on the patient when you transport them. So, you know, I don't think it's a kind of a black and white area. I think there's some gray areas there. But again, I think if, you know, that high quality CT is negative, I think you're pretty confident that cervical spine should be stable. And again, I think that's the only two standards I have in this talk. Everything else is an option or a guideline. Okay, so here's one's probably a little more controversial, but type 2 odontoid fractures. So, you know, common fractures, usually type 2, definitely can be unstable. Probably the hardest to heal also. You know, You can describe them as displaced, non-displaced. Can occur with flexion or extension. Flexion is probably more common. The one here we have is posterior displaced. So what, to treat these, there's no standards. Guideline is age greater than 50. And honestly, I'm just around 50 and I don't feel like I'm any different than 30. So I don't think I want to be thought of as different than a 30-year-old. And again, that goes into, how good a shape somebody's in. Are they active? Do they smoke? So the age thing always bothers me now that I'm close to 50. I don't think we can use that as a cutoff all the time. Displacement greater than 5 millimeters, that's an option, saying that should be surgically treated. If the fracture is in many pieces, again, option that should be surgically treated. I think this last one is, again, an option, but something I use a lot is, the stability in a collar. If you put them in a collar and it slips compared to, upright versus supine or even, versus the CT scan, I'm not sure that collar is stable enough. And that might be a good reason to surgically fix it acutely. So here are just some cases. And again, I think I'm just bringing this up to say, look, you can't treat everybody exactly the same, and kind of what does age mean? 78-year-old with some medical problems, who's pretty sedentary, a C2 fracture, if they're not climbing ladders and have a real low risk of falling and they know what their risk is, that's not something I'm going to charge in and operate on, somebody I'm going to operate on. Like I said, a 52-year-old, but healthy, exercising, that's somebody who may have really good bone quality and maybe they will heal on the collar. 22-year-old, same thing. And again, those are the people who are going to do best with surgery too, because the bone is the best. And then a 90-year-old, who's in a nursing home, basically doesn't go out. I mean, that for me, that is a difficult person to say, I want to operate on that person. So, and the population we see here mainly are the elderly people who have a fall or something, and you find the C2 fracture, and, and I think they're a lot of times are the most difficult. And you talk to these people and they really don't want surgery. The risk of surgery is real, and, they'll lose some motion in the neck. I mean, so for these people, sometimes I'll get an MRI just to see, how big is the spinal canal? We know the spinal canal is big at that point, right? The cord usually has a ton of room. So if the cord really has a ton of room there, the cord doesn't have a ding in it, it's not injured, I think all those are reasons, and the patient understands that they just can't put themselves at risk for falling. I think those are all, reasonable things to say to the patient, and the patient can make the decision, do they want the operation or not? I use flexion extension MRIs sometimes. I think this is probably a good use of flexion extension MRI. One of the problems, we don't have an upright MRI, so our flexion extension MRIs are supine. I'm not sure if they're as good as upright, but these are interesting studies. And if you see that the spinal canal really changes in dimension between flexion and extension, again, that's a good indication that maybe you should fix this. Surgery, we have good surgeries to fix it, odontoid screw, posterior C1-2 fusion, both are very good surgeries, but both have risk. I mean, there's a real risk with both surgeries. And, depending on who the patient is, you need to talk to them about that. Especially in elderly patients, what if the fracture doesn't heal? Is that okay? Do we need to go back and fix it later? They don't have any neck pain. And there's studies, this is a study that we published, but there's studies out there that basically say that the risk of developing myelopathy or some type of catastrophic injury is pretty low with these non-unions. And again, like I said, I discuss with the patient, I'm like, you have to avoid any activity that puts you at risk for falling, no ladders, no steps, be careful. And I think in conclusion on type 2 dense fractures, for me, I just have to be convinced that I need to fix it. If I can't convince myself I need to fix it and the patient doesn't agree with me, then we will let that, we'll follow them. Let's see, the next one's management of facet dislocations. So here's a case we had, 35-year-old man, non-restrained, motor vehicle accident, facet C6-7, facet dislocation, actually the C6 vertebral body is in front of the C7 vertebral body, complete spinal cord injury. If you can look at on the right side here, you can see the facet are locked. Pretty significant injury. So then you can start talking about how we're going to fix this, closed versus open reduction. Again, these are options, not even guidelines. Treatment and a brace or surgical stabilization. I think in this case, I think most people are going to surgically stabilize this at some point. But do you reduce it first, closed, with traction? And there's papers out there. This is a paper from 1999 where, looking at, traumatic disc herniation, is there a neurologic or risk of neurologic injury, doing this closed reduction before MRI, and they showed you didn't need an MRI. So I think it's definitely an option to do a closed reduction. What I kind of find in my practice is that, to get all the equipment there to do the closed reduction takes some time, and we're almost more efficient at getting an MRI quickly and going to the OR. So most of the time, if we know we're gonna have to go to the OR to reduce it anyway, or at least to stabilize it, we're gonna reduce it in the OR and not before we get to the OR. If you do decide you're gonna do a closed reduction, you have to, figure out how much weight you want to use, or you give them some medications, and then there's little tricks where people talk about maybe some flexion and, definitely an option, but again, I think it's very specific to the hospital and the surgeon. I think we'll never make, luckily, medicine's still somewhat of an art, and I think we all have our skill set and how we fix things the best, and it's okay that not everybody does everything exactly the same. So an open reduction, so, even here, this is the engineer in me. I mean, how do you fix this? This is, it's almost locked up front and in the back. Do you go for the front first and see if you can distract it, reduce it, and then go to the back? I usually look at these things as what's really holding me back from fixing this. And in this one, I thought it was locked facet. So we started in the back. I like starting in the back too, because then I do a laminectomy to open up around the spinal cord. And as you're reducing it, give the spinal cord room. I think it's, again, it's a complete injury. Maybe it really doesn't matter, but at least I feel better knowing that spinal cord has some room as I manipulate the spine and try to reduce it. So we went to the back, reduced it. This patient, we actually had then go to the front and actually reduce from the front too, because those bodies were locked in the front. Then we fixed in the front, fused in the front, and then went back to the back to put in our instrumentation. So it took a long time, but I think for this patient, we were able to limit it to kind of a 1-level surgery and get a really good fixation that we don't need to worry about, this becoming unstable down the road, or we need to come back and do something else. And again, I think our goal of surgery here really wasn't to getting neurologic function back, but it was really to stabilize the spine. And I think we did that pretty well. I think in this patient too, did not have a significant facet fracture. So that's why I also thought going from the back made sense, because we actually had to drill that facet off to reduce this, or at least allow it to be in a position to be reduced when we went up front to do our anterior reduction. This is kind of a slide just with my thinking on it. So a lot of times I do like to approach these posteriorly just because I think that's where the pathology is, and you can do the laminectomy. And again, I try to minimize the levels. So there's also some people out there who've published some really great surgeries. I have to admit, I don't always get away with this, but I've tried it, and it's worked at times. But you can try to do something like this, and this is probably not a good example. But if it wasn't quite as translated, go in and put your distraction pins in the vertebral bodies, and then actually give it a little more kyphosis there to unlock your facets, and then reduce it. And that way you do an ACDF and you're done. And I think, for facet dislocations that aren't as extreme as this, that's a very good way to do it. But again, you have to be prepared that if it doesn't reduce, then you may have to go from the back too. And then here's another way where somebody describes doing everything from the back, where they use pedicle screws as just really secure fixation to get in there, reduce this, and fixate it and not have to go from the front too. So again, I think this, if you look at the translation here, it's less than 50%. May have been a unilateral facet dislocation, right? Less than 50%, but this worked well. So this is that same case again. And then, post-operatively, what do you do? I'm not, I try to stay away from collars. I really don't use halos anymore. If I get really good purchase with my instrumentation, especially if I do 360, a lot of times I think that's going to hold things well enough and just follow with serial x-rays. Some people go bicortical, it's kind of an old school thing with your anterior cervical screws into the body and give you even better purchase. If the end plates are still intact when you're putting your interbody graft in, that makes you feel better about the stability. Again, with MRI, if you see your posterior ligaments are disrupted and the joints are disrupted, that may make you want to say, look, I need to fixate posteriorly also. And then even, what's the patient going to do after surgery? If they're complete injury and they're not going to do as much, you may be confident that anterior fixation is enough. If they're incomplete, they're going to be in rehab, then, that's something where you may really want to do a 360 to make sure that fixation is really strong. And then finally, a little bit on the collar, like I said, I'll use a collar still at times. And a lot of times that is just more for, I think, everybody to know that this patient had surgery and they need to take it easy on them, especially when they're transferring them. I don't use halos much anymore. I'm not sure if anybody does, but I just find them cumbersome and almost worse than surgery for patients. And then this is just a final case I just brought up. If we want to have some discussion about it, I don't have much on this, but this is another difficult one, a C7 burst fracture. And, I'm sure, people that have been practiced for a while will get these transferred in because they were done at a different hospital and they did something and it fell apart. But, doing that ACD or doing the corpectomy and fixating down to T1 it can be quite difficult at times. I think this is one where you definitely have to think about instrumenting anteriorly and posteriorly. There are some tricks where you can, with the old Synthes gold plate, you could turn it upside down so that T1 is the top part of the plate and that screw has an easier angle to get that screw in there. Trauma, you probably want to use a fixed plate. But the C7T1 is never an easy disc space to get to. But I think this is one where definitely you want to do an anterior. And when I've seen these come into the hospital that are transferred in from somewhere else that had an issue, it's usually they haven't gone posteriorly. So I think the posterior construct is really helpful with these. And just to finish up quickly here, again, most of these are suggestions. I think luckily we still need to think as surgeons and that's the best part of the job is we have to figure out how to fix these things. And it's not just an algorithm. Use these guidelines to make your plan. And I think experience really does matter. As you see these things, we can't, the senior surgeons, they have so much knowledge to give to us. We need to listen to them. If medicine becomes an algorithm, physicians, we're not needed anymore. And this is, I think this is from somebody from MIT. I saw this at a talk once, it's the blueberry muffin versus the chihuahua and artificial intelligence can't tell the difference yet. So luckily we can. And then just to summarize, no one right answer. It's okay that different surgeons do different things. We all have a different set of skill sets. Always remember you're going to treat the patient like it's your family member. Just don't operate to operate. And, it's okay to follow up with CTs and x-rays. And if you see something you don't like, it's okay to go back in there and fix it. Thank you.
Well, thank you very much, Dr. Reiter, for this very comprehensive presentation. And I think you mentioned all the difficult cases in cervical trauma. From my side, I would have a question regarding MRI. You mentioned MRI and the role of MRI, but it's not clear for which cases. Personally, I do MRIs in those trauma cases where you see some trauma consequence in these CT images, but where from the bony status, I would not go for surgery, but I would go for conservative treatment. Before I go really decide on conservative, I always do MRI. For the surgical cases, for most of those cases, MRI doesn't change a lot, and therefore, if the decision for surgery is clear, in my practice at Intramedullary, would you comment on this? Would you see it in the same way, or would you say this is no, you would see differently?
Yeah, I guess I use MRI differently. I like to use the MRI, one, to look at how quickly I need to do the case. So if there's, spinal cord compromise, I'm probably more aggressive with surgery. If there's no compromise, I may sit on it longer. I get a little worried though, if the CT, looks okay and I get the MRI, that's going to show me things that maybe are going to make me kind of question if I need to do anything. I really like upright flexion extension, or just upright x-rays in a collar. And then at some point, flexion extension x-rays, upright weight bearing. I think for stability, those are what I like the most. So yeah, I guess my algorithm is usually kind of the CT scan. If it has a fracture, I'll put them in a collar, see if they're stable upright. If it's a fracture that I think I need to fix, I'll just fix it. But I usually do get an MRI pre-surgery just to make sure there's nothing additional I think I need to do during the surgery.
Okay. Do we have any further questions?
There appears to be one question in the chat.
In the chat box, there are 10 questions.
You want to read it for
Yeah, I don't.
Dr.
So
Coleman?
here's one for a patient with cervical disc and a thoracic as well. We had one case, although it's very rare. What will be your approach? She had a quadriparesis. I think it's a cervical disc trauma and a thoracic as well. The quadriparesis, yes.
Yeah, I think I would address the cervical spine first. If you can address them both at the same time, I guess it's probably the easiest thing to do, but start with the cervical spine because I think that's the major issue.
Okay, could you comment on the timing for decompression of a spinal cord injury? When would you go for when would you decompress a spinal cord injury? What is the timing at your institution? If the patient comes in at, let's say, 7 o'clock on a Friday evening, as always.
That's like the toughest question.
Yeah.
So yeah, and that's still, there's no good answer. I think the only one that we definitely, most of us would be aggressive with is the patient with the incomplete injury with spinal cord compression on MRI. I think we're going to want to go in there and fix that. I think that's definitely something that you could see some improvement. For the complete injury who comes in, that the spinal cord looks terrible on MRI, that's something that, we may not do in the middle of the night just because probably doing the surgery during the day is, you'll get a better surgical result. The team will be more, you have a better team in there. So that comes in at 3 a.m. We'd probably start that at 7:30 or something. We usually don't let patients wait too long. We try to get them done within kind of the next day, but that's a tough question. I don't have a good answer for that. For the patient who comes in who's just unstable, who has, but the spine is unstable, but spinal cord is normal, their exam's normal, we will usually just keep them on spine precautions until the next day and do that as a 7:30 in the morning case again, because I think you do a better job during the day than in the middle of the night.
It's a question for absolute contraindications for traction in cervical spine injury.
I think you're looking at just the level and how much weight you're going to put on. There's definitely reports out there with traumatic disc herniations where you make people worse. So, you need to have an awake patient, you can't sedate them. But an absolute contraindication, I can't think of one. I don't know if anybody else can think of one. Okay.
And just a quick comment, posterior C1, C2, Harms technique or transarticular?
We probably end up doing more of Harms technique than transarticular at this point. I've done them both.
Okay. Well, why would you prefer Harms? Because of the vertebral artery risk, which is just better controllable, or?
Yeah, I just, I don't know if I have a good reason for it. I think it feels safer. Does that make sense?
Just in terms of,
yes.
Okay. Interrupting, but just in terms of nosology, and Professor Gall is here. we like to call it goal harms technique from this side. So,
Of course.
what do you call in term, because Professor Go has described it first, but this is just so that propriety is maintained. Sorry for interrupting. Carry on, please.
The other thing with the transarticular screws is, I mean, not everybody can accept those. I mean, you really have to be careful looking at your CT and be pretty confident that there's enough bone there to put the screw through.
Okay, here's another question for vascular assessment prior to surgery for cervical trauma. In which cases and when do you decide to do a vascular assessment like CTA prior to surgery for cervical trauma? For which cases of surgical trauma?
Yeah, I mean, at this point, everybody who gets a CT pretty much and has a fracture or a facet dislocation gets a CTA. Just it's done just because they're there and they see it. You know, I think if you look at I think Jefferson published a paper and it's incredibly high incidence of some type of vertebral injury or abnormality in facet dislocations. So I think, I don't know if it's going to make you do anything different. So I don't use that to make a decision so much about the patient until afterwards. If you want to treat the vertebral problem, if you think you need to anticoagulate them or something, but when I'm doing the surgery, I'm trying not to think about it, but there's a vertebral injury in there probably somewhere.
Okay. And the answer is one. I think this is an important question because it's just upcoming that we learn that the intradural pressure is important in spinal cord injury as well. There's a question in severe spinal cord injury. Do you have experience in early durotomy with expansile duroplasty?
I do not. Yeah. It's an interesting, I think it's an interesting comment or an interesting concept. I haven't seen a lot of literature on it yet, but at least my teaching was that doing a durotomy is not going to help.
I don't do it for the time being, but I think this is something which is in research and progress where we learn more and more that could be potentially helpful. We need to wait for the data which to prove that the duroplasty is helpful. Okay, yes. These were all questions from the chat box. Naren?
Thank you very much, Professor Ringel, and thank you very much, Dr. Prasad. It was a fantastic session. It has been the same throughout the whole day. I just want to thank all the speakers who have taken their time on a Saturday and on a very short notice, and the quality of presentations have been absolutely stellar. I want to thank Professor Miguel Arez, who is here. Thank you very much, Miguel, for supporting the INRC from the beginning.
My pleasure. Thank you, Naren.
Thank you very much, and look forward to working with you. And I want to leave the last words of this course with Dr. Prasad, who has organized the INRC in India, which we will have it once everything is settled, but also was very instrumental in getting all the audience here. And we had a discussion last Sunday, and within 6 days we have organized this meeting. And that's mainly due to the generosity of the faculty. And also, I think we have in this meeting, set new standards. I think, the listserv started webinars back in 2011, but we have now had a 1-day full comprehensive course with lots of questions. People can ask questions directly. People can ask direction questions from the chat box, and the live feed has gone to YouTube and it's been recorded there. So in terms of a lot of innovations that we have brought, actually in terms of the academic quality, I think this has been an outstanding meeting. But Dr. Prasad, first of all, Professor Miguel Arez, some words. And before I give it to Dr. Miguel Arez, I really am touched by the senior surgeons who have been here. Professor Goel has been here since the morning. Dr. Patkar has been here since the morning. And it really is quite moving that senior people have come here and been here and asked questions and commented, which is really impressive. Professor Miguel.
Thank you, Naren. I don't want to take much of your time because it's very late. I'd like to outline a couple of things. First of all, just to congratulate on you again for this fantastic course and this wonderful educational activity. And second, just to let you know that I really enjoy all the presentation and all the topics, terrific, lecturers, and I hope we will have a next one very soon. Thank you very much, Naren, in behalf of all the faculty.
Thank you. I think the attendance has been great. All the delegates have been very engaging, and I think that's mainly due to Komal. Dr. Prasad, please. Yours
Thank
is the
you
last
very
one.
much. It's an excellent course, and I enjoyed every moment of it. And we are sitting right from the morning. And you know what, Naren, the time here in India is 12:39 a.m. We're nearing 1 a.m. And it's so nice to see more than 80 people now still logged in from various corners of the world. I am thankful to each one of you to make this a grand success. The best way to utilize the time when we are in the middle of this kind of pandemic, when we are all locked down. So we have best utilized this day to share the knowledge. Thanks to all the seniors who are there. I'm seeing Professor Goel, Professor Constant, Professor Sushil Patkar, Dr. Maigil. So thank you each and every one of you for making this wonderful experience.
Thank you very much, Dr. Prasad. I'm sure we'll go through the other specialties as well. The faculty, I will be sending you the certificates, and for the delegates, please fill the feedback form, and I will get the certificates to you in the next 3 to 4 weeks. Thank you very much, and wishing you all safety and health to your loved ones, you and all your charges.
Thank you, sir.
Thank you. Have a very nice weekend. Okay, bye.
Thank you all.
Thank you.
Aguanta ahí un rato, porque es que sabía yo que al final tenía que decir algo. Bueno, madre mía.